Right, so we've got a mixture of first, second, third year medical students here. Anybody any different from that? Fourth year as well. Excellent, lovely. Okay, so I'm going to tell you a little bit about my story and how I became a consultant in emergency medicine in SEMS. And I'm going to talk a little bit about my pathway, my training. I'm going to talk a little bit about the normal routes into emergency medicine, the kind of things we do, what a day in the life of being an emergency medicine physician is like, and hopefully be here to answer some questions, bust some myths for you, hopefully inspire you to also become emergency physicians in the future. So I'm going to take myself back to when I was kind of in your position, sat in your seats. How many of you have an idea what you want to do in the future? I'm guessing by the fact that some of you are in this room that some of you consider emergency medicine as a specialty you might want to do. But how many of you think you really know what you want to do when you graduate and when you become consultants? 1, 2, 3, 4. Okay, so not many of you. Okay, how many of you have some idea of what sort of field of medicine you want to go into? Yeah, a few more. Okay. How many of you, before you got to medical school, had any idea of what you wanted to do? A few people. Okay, good. So you're in a better position than I was, because I had no clue at this stage as to what I wanted to be. I think I graduated and was probably about 3 or 4 years into my medical career before I found emergency medicine. Okay, so I think you guys are already on a head start from where I was. Okay. So when I went to medical school, I went to medical school in London. Sorry, there are other medical schools. But I was at Imperial College. I spent 6 years there training. I did an intercalated BSc in healthcare management. Okay, so nothing to do with anything clinical, nothing to do with emergency medicine at all. I had no idea what I wanted to do. All I knew is I wanted to graduate, become a foundation doctor, get through my foundation training, and then maybe become a consultant in something at some point. Okay. So fast forward a few years, got to the end of medical school, still wasn't sure if I wanted what I wanted to do. I wasn't actually sure if I wanted to continue doing medicine at that point. But moved down to the south, moved down to Bournemouth to start my foundation training. I did 2 years of foundation training in Bournemouth Hospital. During that time, one of my rotations in my foundation year 2 was emergency medicine. And suddenly I found something that I thought I really liked. So my foundation program started off with cardiology. I thought I loved cardiology when I was there. It was great, I wanted to be a cardiologist. I then went and did some acute medicine. I thought, oh, I love acute medicine, I want to be an acute medic. I then went and did some psychiatry. I was like, no, not so much for me. But eventually did a 4-month placement in emergency medicine and really enjoyed it. And that was solidified because I went off from that to do some elderly care medicine for 4 months. And I was like, no, I definitely want to go back to the emergency department. So why did I like emergency medicine? Not sure really. I love the team that I work with. Okay, so as an emergency medicine doctor, you work in a team with lots of other doctors, with lots of nurses, with lots of other healthcare professionals, HCAs, and you're all working on the shop floor and you're all together. Okay, I love that. I love working with other people. And the hierarchies were quite flattened. Okay, so as a junior doctor working in the emergency department, all of our consultants were on first name basis. Okay, we worked really closely with all the nursing staff. They told us what to do a lot, we listened. Okay, so the first rule of emergency medicine, listen to what the nurses say. And that environment was great. I also liked the fact that we were seeing patients that we didn't really know what was going on with them a lot of the time. And it's quite a rare thing in medicine. If you work on a ward, by the time the patient gets to you, you have some idea of what's going on with them. And you have this story which has been through many different hands, and the patient has already probably told it 1 million times. Okay, and you kind of have an idea what's going on. What I love about emergency medicine is you have no idea what's coming through the door. And like some of your colleagues said earlier, every day is different. Okay, we see surgical presentations, we see medical presentations, we see trauma, okay, we see really sick people, we see some people that aren't sick at all. Okay, but it's great, you get something different and there's something for everyone there. So I really enjoyed that about emergency medicine. The downside of it was that there was lots of long shifts as a junior doctor. Okay, back in those days we worked 12-hour shifts quite regularly. We worked 7 nights in a row. Okay, thankfully not allowed anymore. And it was quite tiring. So for me it was a question of, is this something that I want to do longer term? So my route into emergency medicine was, having finished my foundation programme, I then applied for a junior fellow post at Bournemouth A&E, where I stayed for another 6 months, okay, working same as a junior fellow, so same level as the foundation doctors, and having done another 6 months on the same rota. If it was going to break me, it was going to break me, and it didn't. And I thought, actually, I can do this. I really like it. And at that point, one of my consultants said to me, "It's like, don't look at the job you're doing now, and I'll take this for any specialty that you choose to do, and it's okay if it's not my specialty." All right. But a consultant at that time said to me, "Don't look at the job that you're doing now. Look at the job that your bosses are doing. Look at the jobs that your consultants are doing, and if that's the job you want to do, then that's the specialty for you." Okay. So you will experience this as you go onto the wards as medical students. You'll see the jobs that your junior doctors are doing, you'll see your jobs that your senior residents are doing, and you probably won't see that much of the job that your consultants are doing. Okay, but actually that's what you're going to do for 20 years of your career. You'll spend 10 to 15 years training to get there, and then you'll spend 20 years doing one job at the end of it. Okay, so that was a really good bit of advice, and actually I looked at what emergency medicine consultants did, and I really liked it. I thought, yeah, I can do that. I quite like it. I like the different patients. I like working in the teams. Okay, I like the variety of patients coming. I even like the shift work, and so that was quite good for me. So having done 6 months as a junior fellow in the emergency department, I decided to take a bit of time for myself. So I carried on, and I decided to locum for a while, which was lovely. I worked a 3-day week. I got paid nearly the same as I did as a full-time employee, but it's not sustainable. You don't actually progress that much in your career working as a locum, so it's great for a day-to-day kind of work, but I wasn't really moving on. So I applied for specialty training in emergency medicine. So I applied for my ACCS job. I got a job. It wasn't in Wessex at the time. I had to move up to East of England for my foundation job. So something to be aware of when you apply for specialty jobs in the future. Okay, they may not be exactly where you want them to be. So I had to move up to East of England. I spent 3 years up in East of England, and worked at 2 different hospitals up there, and I did my ACCS training, which is the initial training for emergency medicine. During that time, we spent 6 months in emergency medicine, 6 months doing acute medicine, and then a year of doing anaesthetics and ITU. And that was brilliant. I absolutely loved it. Particularly loved ITU, which was a bit worrying. And what did I like about ITU? I liked working with the sickest patients in the hospital. I liked doing lots of procedures. I liked using my brain to think a bit as well. Okay, and I just really enjoyed it. And I almost left emergency medicine to go and do ITU until I looked at the job that my bosses did, and I realised that my bosses in ITU spent a lot of their time scratching their head trying to work out what was going on and breaking a lot of bad news to the families of their patients. And that wasn't what I liked. I liked the practical side, the procedures, I liked all of those. And emergency medicine gave me all of those things. So I went back to emergency medicine, continued with my training through to I got to ST4, so specialty training year 4 years into emergency medicine training. At that point I started thinking, is this really what I want to do? Is there something more that I can do? And then I found that emergency medicine also has lots of subspecialty training. So you can do pediatric emergency medicine, you can do pre-hospital emergency medicine, which is what I do. You can even dual accredit with intensive care. Okay, so I could have been an intensive care doctor and an emergency medicine doctor. But actually, if I go back to what I was thinking earlier, what I really like is the practical side. I really like looking after sick patients, and the best place you can do that is in pre-hospital emergency medicine. Okay, taking your skills and working with the sickest patients right at the start of their journey, when you've known almost nothing about them. So all the bits that I loved about emergency medicine, I found that I could also do in a pre-hospital environment, and the best thing about that is I work in a small team, okay, with some very, very skilled people, and we get to deliver hospital level care to those that need it right at the start of their journey. We then get to feed them into the system, into the emergency department, and then help their journey on in the hospital. Okay. So at that point I decided I really want to do pre-hospital emergency medicine as well as emergency medicine. I better apply for that. So you can only apply for that when you become an ST4, and you kind of have to finish your training before you're an ST6, and you leave your training. Pre-hospital emergency medicine is quite competitive, so I decided to go off and do a few extra things to bolster my application for that. I saw what was around. I found that there was a fellowship with the ambulance service, so I actually left my training program for a year, or I did it part-time for a year, to go and do education within the ambulance service. So I was working as a clinical education fellow within the ambulance service, helping to deliver some simulation education to paramedics. At the same time, I was kind of continuing with my emergency medicine training. And I did that for a year and a half, which helped my application, got into FEM training. Had to move up to Oxford for 2 years to do my FEM training, and eventually finished all of that, signed off as a consultant in emergency medicine, and moved back to Southampton, which is where I now work at Southampton as a consultant in emergency medicine and pre-hospital emergency medicine. So my job at the moment, what does it involve? So I work at Southampton General Hospital. Okay, Southampton General Hospital is one of the major trauma centres in the country. Okay, I don't know if you know anything about major trauma centres, but essentially the whole country is split up into lots of different networks. Okay, here we're in the Wessex Trauma Network, and what you have is you have a major trauma centre in the middle of it, okay, and you have lots of other units around the side. The major trauma centres get the sickest trauma patients in the region, all get delivered there, because we have all the specialty care, we have all the expertise to deal with that. And I love that, because it fits in with all of the parts of my job. It fits in nicely with the pre-hospital work I do. It means that I get to see the sickest trauma patients in the region. They all get delivered, so from as far across as Dorchester on one side to Portsmouth on the other side, up to Salisbury. All those patients, any trauma patient within that region gets delivered to us at Southampton. Okay. I love that, and I love the fact that we have lots of tertiary specialties on site, so we see lots of weird and wonderfuls as well. Okay, and I get to work with a great team within the emergency department. So what does my team look like now? I'm one of about 40 consultants working in the department. Okay, there's quite a lot of us, we're quite a big department. We have probably 10 registrars working, okay, and 40 junior residents as part of our medical team. We also work alongside a lot of advanced clinical practitioners, so that have either come from a paramedical nursing background, who have then changed their skill set and they work alongside our junior clinicians as well. Okay. We have a huge number, probably double the number of nursing staff compared to the clinical staff. Okay, we get to work with everybody else. We work closely with all the other specialties in the hospital, so you get to touch in with cardiology, you get to speak to the acute medics quite a lot, to the surgeons, etc. And that's kind of my day-to-day job. So how does it look now? What do I do? Because like I said earlier, think about the job that your bosses do. So my job currently now, I do about 2 shifts a week in the emergency department. I still have to do nights, okay. I do nights every month, basically. I do a lot of weekends work, but I do only have to do 2 shifts a week. So that kind of balances it off, okay. So although you work lots of out of hours, you work lots of evenings, lots of weekends, you also get a lot of days in the week free, which I love. I love on a Monday morning when I can get up and go to the beach and do the stuff that I enjoy doing whilst everybody else goes to work. Isn't that fantastic? Okay. It's not for everybody, but for me that works brilliantly. Okay, so that's 2 of my days a week. 1 day a week I work with the air ambulance, so I've got to Thruxton, that's where I was today. Okay, and I would do a shift with the air ambulance. That involves working alongside a critical care paramedic and myself, either on a helicopter or on the car, with a pilot helping us out. Okay, and we can get call outs to jobs anywhere in the region. Okay, when we're not out doing a job, we get loads of time on base, and when we're doing that, we get to train. Okay, so there's not many other specialties where you actually get time as a consultant to still train, to still brush up your clinical skills, to learn more, and I love that as well. We talk about cases and all those kind of things. So it's a great job. So that's 3 days of a week, and then I have 1 day a week where I have to do lots of other boring stuff that all consultants have to do, like meetings, clinical governance, case reviews, all of that kind of thing. So that's kind of where I am. Okay. So what's the training route into emergency medicine? So basically you finish your foundation program and then you have to apply for your specialty training. Okay. People take gaps in between that, but essentially you finish medical school, you complete a foundation program, and then you go into your specialty training. Specialty training for emergency medicine involves the ACCS, which is acute care common STEM. Okay, so that's the same first 2 years of training that anybody that does acute medicine, intensive care, and some anaesthetists do. So during that 2 years, that's the 2 years I described, where you do 6 months of emergency medicine, 6 months of acute medicine, 6 months of anaesthetics, and 6 months of ITU. Okay. After that, you have that acute care common STEM is a run-through program to emergency medicine. You then go on to do a further 4 years, so you're ST3, 4, 5, and 6. Okay, during which time you have to pass some exams, unfortunately. Okay, which is the FRChem. Okay, so a fellow of the Royal College of Emergency Medicine exams. You have to do a few projects along the way. You have to do some other bits and pieces, management tests, and complete a portfolio. After which you'll get signed off as a consultant in emergency medicine. If you choose to do your subspecialty training, you tend to do it in one of your last 3 years. Okay, you can apply separately to that, and that usually adds in an extra 1 or 2 years into your training, depending on the subspecialty that you choose. And then after that, the world is your oyster. Okay. The good thing about emergency medicine is it's pretty much recognised all around the world. Okay, every country needs emergency physicians, so regardless of where you want to work in the world, there's probably a job for you. Emergency medicine in this region is actually quite competitive now. Okay, I think there's probably about 3 applicants for every 1 post in emergency medicine at ACCS, and probably there's just about enough consultant jobs for everybody that finishes training to get one. Certainly around the country they're still short, but currently in our region we're starting to get to the point where it's popular enough that the jobs are kind of one-to-one. That's probably where I am with emergency medicine. Have any of you got any questions or anything that you'd like to ask about emergency medicine? Or my job, or any other part of it? Yeah.
If you wanted to go full-time with the airline service, is that an option for you, or no?
So not many people do, and the reason that not many people do is because actually it's really useful to have a base specialty. So to do pre-hospital emergency medicine, you need to either come from an anaesthetic background, an emergency medicine background, or an intensive care background. Those are really the only 3 routes into pre-hospital care at the moment. There is still some volunteer routes, but actually most people are doing it professionally as a, as a paid role now. There are a few doctors around the country that do full-time HEMS or full-time pre-hospital care, but actually most of us find that doing some work within our base specialty helps us in terms of keeping skills set up, seeing larger numbers of patients, following cases through and continuing to learn from that side of things. If you go into just pre-hospital care as a single job and that's all you do, you see a very small group of patients and you don't see that many of them. Okay, so in emergency medicine I can see up to 20 patients a day, all right. Whereas in my pre-hospital work I'm probably only seeing 1 or 2 or maybe 3 patients in a day. Okay. So just for fewer patient volume. I was going to say that within the emergency department as well, emergency medicine isn't just one big homogenous thing, so we can work within different areas within our emergency department as well. So of my 2 days a week that I have split up, on one shift I might be in majors, okay, running the whole department, which means that I tend to sort of be stood back a little bit, helping the nurses coordinate stuff, helping the managers coordinate stuff, and doing lots of senior reviews of other cases that all of our junior team are seeing. Another day I might be in resus and I might be in there with a junior resident or a registrar, and just two or three of us seeing lots of really sick patients and working quite hard clinically seeing patients there. Or I might be over in minor injuries helping assess patients there. So there's variety within emergency medicine as well. I think there was a question on that.
I was just wondering, for the stuff, what other base specialties do people come from?
So it's anaesthetics and critical care. And those that do anaesthetics have to have done the ACCS route because they have to have done the 6 months of emergency medicine, and likewise for the critical care.
If you do the ACCS route and then while you're in there, you change your mind and decide you want to be an ITU doctor or an anaesthetist and not emergency medicine afterwards, is it easy to then change, or do you kind of have to?
So you have to reapply. So it used to be that you could actually switch stream quite easily. Now it's not so easy, but if you've applied for ACCS emergency medicine and you've done your ST1 and ST2, you could apply to go straight into ST2 anaesthetics. You wouldn't have to do the ST1 anaesthetics because you'll have covered that curriculum. Likewise, the other way around, if you did ACCS anaesthetics and changed your mind, then you could come to emergency medicine. We have people that go down the emergency medicine route and then do the subspecialty training in intensive care. So they dual accredit as both emergency medicine and intensive care. And then many of them, when you look at them 5 years down the line, are only doing one of the specialties. They're either doing critical care or emergency medicine rather than doing both of them.
What sort of diagnostic tools do you have on the air ambulance, and like what clinical decisions do you find like most difficult comparative to when you're in hospital?
Yeah, that's a great question. So, what kind of diagnostic stuff do we have? Compared to a hospital, almost nothing. Compared to an ambulance, loads of stuff. So, on the air ambulance, diagnostically, we carry an ultrasound, so portable ultrasound. That's quite useful if we think a patient's bleeding. We can do a bit of cavity triage, see if there's signs of blood in the abdomen. We can have a look at the lungs, see if the lungs are inflated or if there's a pneumothorax or something like that. We've just started carrying point of care blood testing, so we can do arterial blood gases on a little portable machine which we carry in our bag from the air ambulance. And other than that, it's hands, eyes, ears, and that's pretty much it. Versus the hospital where you have CT scanners and everything else that you need there. So that's what probably one of the biggest challenges is making decisions with limited information. The other question you asked was, what's the most difficult thing?
Decisions do you find most difficult making?
So there's lots of things we can do in pre-hospital emergency medicine. We can deliver anaesthetics on the roadside. We can open chests for patients that have arrested. We can treat seizures. We can do thoracoscopies. We can do lots of things. And the hardest decision in pre-hospital medicine is not to do them. Okay, so just because we can do lots of stuff doesn't mean it's always the right thing to do. And just because we have the skills doesn't mean that it's the right place or the right time or the right patient. So if you ask me what I think the most difficult thing is deciding not to do stuff we can do and not doing stuff that we're sometimes called out to do. So quite often paramedic crews will be struggling and they'll call us thinking that we're going to deliver an intervention, and actually it's not the best thing, it's not in the patient's best interest to do that. Obviously not the right time or place. That's probably the hardest decisions. Another couple of questions at the back there.
Yeah, can you tell us one of the most interesting cases you've encountered whilst working in emergency medicine?
The most interesting cases that I've encountered whilst working in emergency medicine. That's tricky. I think a lot of, we see interesting cases every day, and different things are interesting to different people. I quite like the cases. So because of my background, because of my pre-hospital critical care, I quite like the patients in resus that are a bit of a conundrum. The ones where you can't really work out what's wrong with them, but they're really sick. And actually, what I quite like doing is working through the physiology of the patient. So we can have a patient that comes in and they're a reduced level of consciousness, and their blood pressure is low, and they're really acidotic on a gas, and you can't work out why. Okay, none of the normal things that we do, none of the normal histories that we say are working out what's wrong with that patient. And all you can do is manage their physiology to improve them and get them as stable as possible, so that we can call our clever friends from critical care down to come and scratch their heads and help us work out what's wrong with the patient. And those are the ones I really like, so I really like working. Those are the most interesting ones to me, is where I have to work really hard to stabilise a patient whilst trying to scratch my head and work out what's wrong with them. They don't happen so often, okay, but I find those cases really interesting. Yeah.
So if you were to specialise in paediatric emergency medicine,
Yeah.
would you do your ED training first and then specialise in doing both colleges, or is it in between and you pick one and then specialise? Or?
Yeah, so there's two ways into paediatric emergency medicine. The best way is to do emergency medicine and then do subspecialty training in paediatric emergency medicine. I'm sure if you speak to a paediatrician, they'll tell you something differently. But I think the best way is to do emergency medicine and then do paediatric emergency medicine subspecialty. Okay, which means that around ST5 time you go and do an extra year, and during that extra year you do some paediatric intensive care, you do a bit of ward paediatrics, and you do a lot of paediatric emergency medicine. Okay, and that will give you emergency medicine with a subspecialty in paediatric emergency medicine. The other way to do it would be to do paediatrics, okay, and then apply for paediatric emergency medicine through paediatrics, okay, which again is an additional year spent doing paediatric emergency medicine, but that then isolates you just to doing paediatric emergency medicine. Oh, there's one at the back in the number two.
How would you rate sort of like Wessex in terms of foundation training as a junior doctor? Would you say it's better to learn in sort of smaller hospitals where you get to see more, do more, comparative to like a bigger hospital like SGH or Bournemouth, where it's a lot bigger, you don't really get to do as much, but you see quite a bit. So how would you sort of rank your experience in Wessex?
So I've been fortunate enough to train across 3 different deaneries. Okay, so I trained in East of England, Wessex, and Thames Valley, and I think by far and away, and this I'm not saying this because I'm biased because I work here, but I think by far and away the place where I had the best training was in Wessex. Okay, for some reason, this is for emergency medicine. I can't say across all specialties. I did my foundation program in Wessex, and I loved it. It was a great team at the time. So Bournemouth and Poole were very much separate hospitals then. There was quite a small, very close-knit group of foundation doctors where we looked after each other really well socially as well as at work. And I really enjoyed that. I found that great. I don't have any experience of foundation programs elsewhere, so I don't know. But specialty training, I think that Wessex emergency medicine specialty training is probably one of the best in the country. And that's having trained at East of England and Thames Valley as well. I think it's really cohesive across the whole region. I think we get the same quality of training regardless of which unit you go to within Wessex. Partly because we're quite a small deanery, and if you live in the middle of it, or if you base yourself somewhere in the middle of it between Southampton and Winchester, you can get to all parts of it relatively easily. And the standard of training and the quality of consultants across the whole region is much more uniform than if you go to a massive deanery like the East of England, which they have to split their deanery into 3 parts because it's so big, and you could be in Kingsland one day and then in Peterborough and then like somewhere down near Essex. So I think, and because of the large geography, there's much more variation. So I think the Wessex is a fantastic deanery to train. And next question.
Kind of a similar question, but in like a hospital like Southampton General, that's the major trauma centre, but then you also have the paediatrics and the adults separate. Do you think it's more beneficial to train in a smaller hospital where you might get, like even within Wessex, where you have to deal with everything that comes in the door, or do you think it's nicer to train in a major trauma centre, but then kids might be cut off and you don't really see them as much?
Yeah, I think doing both is a really good way. So I did my earlier years of my specialty training, so my ST1 and 2, I did in a really small DGH, so I was working up in Bedford in the East of England, which is pretty backyard compared to working in one of the major trauma centres. But it was absolutely fantastic. So probably not quite the same anymore, but as an ST2 doctor, I was holding the ITU on call group. So I was getting to go to see the sickest patients in the hospital and really learning. And there was support there for sure, but actually you were really let go. Whereas if you go to some of the bigger centres, which are much more consultant-led, you tend to get handheld a little bit more. You tend to get the consultant input a lot more. What's better for patient care? Not sure. Right, I think probably having lots of consultant input, but at the same time, it's harder for you to stretch and grow when you don't have that. So I think the best balance is to have a bit of both. Which way round, I'm not sure. So some people prefer to have that stretch when they're more junior and then go to somewhere like a big tertiary centre for learning all the finer detail, the tertiary specialty stuff. Other people would rather have it the other way around, where they have a bit more support when they're junior, and then they go out to, you know, the smaller DGHs in their more senior years where they can stretch their wings a bit. Any other questions? Yeah.
I'm not a question, so my question is not really going to be relevant to or beneficial to people, but it's more to satisfy my own curiosity. That's a H135, right? The helicopter.
That's it, yeah.
How have you found that as a vessel for what you do? Because we know it to be like a more versatile aircraft, and so like a jack of all trades, but sort of master of none. How have you found it as someone who uses it?
So to be fair, so I did all of my training in a 135 in Thames Valley, and I worked on the 135 at Hampshire. I have a bit of experience of the bigger helicopters, so Dorset have a bigger helicopter, for example, and there's pros and cons. So these are really reliable. They can get into small spaces. They're single pilot, so there's lots of advantages. The disadvantages is they're absolutely tiny in the back.
Yeah, exactly.
And actually working on a patient in the back is quite difficult, because you kind of knee to knee with your colleagues, and then your patient's sort of shoved down in the boot basically with just their head and chest showing out of it. That said, we don't transfer that many patients in the helicopter. So the main time we use the helicopter is getting people from the Isle of Wight over to the mainland. And then also if they're in the sort of farther reaches, you know, if you're up towards Salisbury but you need to be in Southampton, it's more than a half an hour road distance, then you start to get a bit of benefit of the helicopter. But a lot of the time it's about getting the team to the patient, and then we can use the ambulance to get the patient to hospital.
Yeah.
So I think that the 135 is a perfect vehicle for that. Dorset use a much bigger helicopter, but they have to cover much further ground, so they cover all the way. Dorset and Somerset is quite a big beach. A lot of it's quite rural. There's quite a lot of transit distance, so they are carrying patients in the aircraft much more often. So it's about choosing the right thing for the right place. My colleagues will probably tell you they're 145. Yep.
Is there any sort of like technology sort of coming out that you're optimistic about or either skeptical about in terms of like across both sides?
I think the biggest change that we're going to see, everybody will give you the same answer. The biggest change that we're going to see in healthcare, particularly in hospitals, is how we use computers and how we use AI to our benefit within hospitals. So at the minute, it's just starting to come in certain specialties. So for example, in stroke care at the minute, if it's in the middle of the night and somebody comes in with a stroke, we no longer just thrombolize them, we actually do thrombectomies. Now, the stroke physicians are sat at home and they put the CT scan through an AI program that tells them whether this patient is likely to benefit from thrombectomy or not. So we're already starting to get there. But I think that's the biggest change that we're going to see is how we use that. And I suspect in radiology is probably going to be one of the bigger areas, and perhaps in some other decision-making processes about whether a patient, for those borderline things, whether a patient would benefit from surgery or not benefit from surgery. I think we'll see a lot of stuff there. In terms of pre-hospital care, what's coming, it's a way down the line, but it's looking more and more like things like ECMO and ECPR. So taking patients and putting them on to bypass during their cardiac arrest, and essentially doing the job of their heart for them whilst their heart can recover and survive. I think that's going to come, but it's already been proven in other countries that it can work. The problem is there's a massive change of the whole system and the whole way we deal with things and which hospitals they go to and who looks after them. So it's a way down the line, but I think that within our careers we'll probably see that. Yep.
So, as like an ED doctor who like specialises in resource and like helicopters, do you ever have to work like in minors? And if you do you find it boring after working in like resource and out on the field?
So any job you do is going to have stuff that you really like doing, stuff that you don't like doing, and stuff that you just have to do. Okay, and emergency medicine is no different from that. Okay, so I'm sure if you ask a cardiology if they wanted to see every non-specific chest pain that comes into the hospital, that would probably be like their least interesting thing. What they probably want to be doing is looking at crazy ECGs and doing lots of electric physiology stuff. Emergency medicine is the same. So I like being in resus. I'm less fussed about seeing the minor illness patients, but actually minor injuries I love. Okay, that's what really got one of the things that got me into emergency medicine in the first place, was seeing people with sports injuries, broken bones, and then actually being able to diagnose them and actually being able to give them some really good advice. Okay, so sports and exercise medicine is something that you can sort of stray into from emergency medicine as well, and I've thought about that for a while, but I really kind of like that, so the involvement of physiotherapy and minor injuries and that kind of stuff as well. So I still find that interesting, and if I get the opportunity to go into minors, which isn't that often anymore, I quite enjoy it. So yeah, you can still get enjoyment out of all the other sides, and then like any job, this is stuff you just have to.
Have you done any expedition medicine? Do you know any colleagues that have done?
So I haven't done it. I haven't done very much expedition medicine myself. I do a bit of event medicine. Okay, so again, another thing, it's not a direct subspecialty of emergency medicine, but it's something that emergency medicine is very suited to. It's things like expedition medicine and event medicine. It's great fun. Certainly the event medicine side of stuff. So providing event medical cover for festivals, being able to go to big sporting events, doing things like the London Marathon, and providing, you know, the finish line medical centre stuff for the London Marathon, Southampton, you know, Great South Run, all of those kind of things, Ironman. You know, it's great fun. It's working with a different team of people. It's kind of that crossover between pre-hospital medicine and in-hospital medicine again. Expedition medicine is something I'd probably like to have done more of, but didn't really discover that kind of world until I was already quite far down my career, by which time freeing myself up for 3 months to go off on expeditions probably didn't really come into play. But if you want to find out about that kind of stuff, one of my colleagues that I work with on the air ambulance spent 6 months working for the British Antarctic Survey, so I'm sure you could ask her to come and talk to you and she'll tell you all about that kind of stuff. And I've got other colleagues that do that would come and talk to you about it. Sounds great, I just kind of missed the boat on it. So.
We've got time for one more question.
I mean, obviously you see some quite tough things with pre-hospital and hospital emergency medicine. How do you deal with sort of what would be quite a tough psychological toll of it, seeing pretty harrowing things?
Yeah, I think that's a really interesting question, because we don't know how we deal with it until we're not dealing with it sometimes. But actually there's lots of things you can do, okay? So we, for example, within pre-hospital medicine, we're really supportive. Quite often after a difficult job, we'll talk to each other as a crew, check in with each other, make sure that each other's okay. There are more formal structures in place as well. So if at any point we think we're struggling, we quite often get a call from one of our leads of the day just to check in with us, and if we need further support, then they can plug us into processes like trim and things like that. Part of it comes from training. Okay, the more you train and the more you inoculate yourself to see these things and be able to deal with it, then the easier it is to cope. So particularly the stress side of things. So being stressed in a really time critical situation is quite tough, and the best way to do that is to slowly immerse yourself in a simulation where training with your team, training difficult communication, all those kind of things, and the more you immerse yourself in that environment, the easier it is to deal with it. So there's certainly that type of thing. And then there has to be the self-recognition part of it. You have to be able to realise when you're struggling, and you have to be open and honest with yourself that actually I'm not okay. And you don't know when that's going to hit you. So you could have seen hundreds of bad cases, and you can go to one job and something will trigger you, and you don't know what it is. It might be that the patient's mum reminds you of your mum, or there's a kid that's the same age as your kid, or whatever it is. You don't know what's going to happen, but you have to be open and honest with yourself and put your hand up and say, actually, I'm not sure if I am okay after that, because then people will help support you. So I think those are the difficult things, but there's plenty of structures in place to help you deal with it. You also have to realise if you're the right sort of person to deal with that, and I think, you know, pre-hospital emergency medicine is fantastic, and it sounds great and looks great and everything else, but the reality of it is it's quite tough, and you see some absolutely horrendous stuff. And it might mean that you're not the right person. Just as much as we want to do that, we might not be the right person to do that job. So you have to have that question with yourself as well. And then there's all the other stuff you do, the self-preservation stuff, the going to the beach on a Monday morning whilst everybody else is at work. That works brilliantly, that really helps.
Yeah, thank you guys for asking some really questions. If we give a round of applause.